Assalamu alaikum. My name's Immad. I'm a third year medical student, and today we'll be doing metabolism and diabetes. Very easy lecture and shouldn't take too long. So let's get started. If you have any problems that you want to ask me later, you can text me, not only about this lecture, about MOL in general, or about first year, anything. Um, let's get started. Bismillah. So, diabetes is not one disease, it's a group of syndromes because there's two types. The first type is called type 1 diabetes mellitus, and the second one's called type 2. This is the nomenclature that's currently used. Before this, type 1 used to be called insulin dependent diabetes mellitus, and type 2 was called non-insulin dependent. And this is due to the treatment regimens in these diseases. So basically, for type 1, the only way to treat it is by administering insulin. That's why it was called insulin dependent. But for type 2, in addition to insulin, there's also a bunch of medications that can be used, and that's why it's called non-insulin dependent. However, this is no longer used because type 2 uh, diabetes mellitus patients eventually also require insulin administration. So it wouldn't be correct to call it non-insulin dependent. And that's why it's no longer called insulin versus non-insulin dependent. Now they're called type 1 and type 2. Type 1, in type 1, there's absolutely zero insulin eventually. And in type 2, you always will have some partial level of insulin in your body, even though it will not be enough to carry out its physiological mechanisms and its actions. So, diabetes is a really common disease. I'm sure you know someone that's suffering from diabetes in your family or, in general. So people tend to downplay how dangerous it is because it's so common. And that's because of how effective the medications are nowadays. But diabetes is really a very deadly disease. And uh, even now, it's the leading cause of adult blindness due to diabetic retinopathy because the excess glucose in the blood basically messes with the proteins and we'll discuss this later. There's a whole slide about it, but it causes a disease called diabetic retinopathy, wherein it affects the retina because of the glucose affecting the structure of the proteins, and this can cause adult blindness. It's also the leading cause of amputations worldwide because of diabetic neuropathy. Basically, what happens is the excess glucose interferes with the structure of the proteins again, leading to a decreased sensation in the peripheral limbs. Because of this, when you hurt yourself accidentally or you happen to knock into something, you wouldn't feel the pain. So you could have a wound and you wouldn't even know because your nerves are so uh, your nerves have reduced sensation because of the changes that diabetes uh, has done to them. And another thing is poor wound healing. And this would be due to the high level of glucose in the blood. Um, the wound wouldn't heal like it should normally. Again, this would further cause an ulcer or a sore that has like progressed so much that it can't be treated anymore, and you just need to amputate the limb. It can also cause renal failure due to diabetic nephropathy. You guys took renal, so you know about the Bowman's capsule, the glomerulus, and all that. So when there's excess glucose, it affects the filtration process, because of which, again, it could cause renal failure. Heart attacks and strokes are also more common in diabetic patients because of vessel occlusion and atherosclerosis that's made more common by the excess glucose. So the excess glucose basically it would play a role in the formation of plaques, which would obviously make the vessel smaller and thinner. Eventually, it would lead to heart attacks and strokes. Stop me at any time if you want me to, if you want me to answer something, or if you want to ask a question. So that's what happens on the macroscopic scale in diabetes. But what about the metabolic and molecular changes, which is what this course really focuses on? Basically, everything that happens in diabetes is the opposite of the function of insulin. So you guys have taken insulin function earlier. Basically, if you remember what insulin does, the opposite of it is what happens in diabetes. So you would have a decrease in the GLUT4 transporters. These transporters are placed by insulin into muscle cells and the fat cells. Basically, it allows glucose to enter the cells so that the cells can perform their function and get energy. So you would have less glucose going to the cells if you have diabetes because you would have less GLUT4 transporters since GLUT4 transporters are placed in the cell membrane by insulin. Secondly, you would have increased glycogenolysis, which is breakdown of glycogen, and and an increase in gluconeogenesis, so more production of glucose, because both of these are inhibited by insulin, and if you don't have insulin, well, they're going to increase. You're going to have decreased glycogenesis, which is formation of glycogen. So your glycogen storage is going to be depleted because it's continuously being broken down, which obviously also increases the level of glucose in the blood. All the three mechanisms, glycogenolysis, glycogenesis, all of them increase glucose in the blood. And the fourth thing is there will be an increase in hormone-sensitive lipase activity and a decrease in lipoprotein lipase. So you guys have done this earlier as well. Hormone-sensitive lipase is the one that breaks down fatty acids, sorry, that breaks down, yeah, fatty acids that are stored in the adipocytes, and lipoprotein lipase is the one that breaks down the ones that are in circulation. So basically, there'd be an increase in the function of hormone-sensitive lipase. It's going to be more efficient and function more than normal, and a decrease in lipoprotein lipase activity. And this plays a major role in some of the pathology of diabetes, which we will see later. So the fourth point is really very important, and you need to remember it. So we've talked a lot about what diabetes is, what it does to the body, but how do you diagnose diabetes? So there's a lot of ways to diagnose them. The most commonly used one is the second one, which is HbA1c, but we'll talk about all of them regardless. The first one is elevated fasting plasma glucose. Basically, what you do is you ask the patient not to eat anything for a period before their blood test. Um, and then once they come in, you take a blood sample from them, you test it, and you measure the glucose levels. And obviously, there's a cutoff range. You don't need to remember the numbers for this. I would recommend you to only remember the ones for HbA1c since it's the most important and the most commonly used test. But basically, if it's above the threshold for elevated fasting plasma glucose, then then it probably means you have diabetes. But just because you have it positive once doesn't mean just if the fasting plasma glucose is elevated once doesn't mean you're diagnosed with diabetes. Each of these tests needs to be positive on two separate occasions to be diagnosed with diabetes because of, normal physiological changes. And so just twice is what is recommended. So it needs to be positive two separate occasions, every test. The second one and the most important one is HbA1c. It's called the glycated hemoglobin test. Basically, what happens is when you have diabetes, you have an excess of glucose in circulation, right? Due to the excess glucose, it's gonna undergo a process called non-enzymatic glycation, and you need to remember that it's non-enzymatic. Basically, what happens is it sticks to the red blood cells, and once you take a sample of the blood, you can tell the amount and the level of glycation. So glycation is the glucose sticking to the red blood cells, and this process is non-enzymatic. It's purely due to the increased glucose in circulation that shouldn't be there. So HbA1c gives us an idea about the previous 3 months of blood glucose levels. So it's a really good test because it doesn't only tell us about the level of glucose now, it gives us a 3-month history. And the reason it gives us a 3-month history is because RBCs are replaced in circulation every 3 months. So an RBC that's been in circulation for 3 months would have these glucose stuck to them over and over. So it'll basically tell us for the previous 3 months the blood glucose level has been like this because it gives you a history of the past as well. So it's a really good test, and that's why it's mainly used in the clinic. It can tell us about treatment efficacy. So let's say a patient comes to you and he's diagnosed with diabetes, and previously his HbA1c was 6.5%. He comes to you after 3 months, and you do the HbA1c again, and this time it's 5.5%, let's say. So now you know that the treatment is really efficient because the previous 3 months, the blood glucose has been controlled uh, in a very good manner, which is why the HbA1c has fallen. So for this, I would recommend you remember that the normal is 5.7%. So a normal HbA1c is 5.7%. If it's between 5.7 and 6.4, that is considered pre-diabetic. Pre-diabetic is not diabetes, but it means you have an increased risk of developing diabetes eventually if you don't change your lifestyle and change what you're doing. And above 6.5% is when you're actually diagnosed with diabetes. If you get 6.5%, two separate times. Yeah. The third test is an OGTT, which is mainly used in gestational diabetes. So it's called the full form is an oral glucose tolerance test, and how it works is you take a very sugary drink, and then 2 hours later your blood sugar is measured. And again, there's a cutoff for this as well, above which it's positive, but you don't need to know the cutoff. And again, this should be positive on two separate occasions, and this is mainly used in gestational diabetes, which is diabetes in a woman that's pregnant, which we'll go over again later. The fourth thing is not really used for diagnosis, but it can show that a person has diabetes. It's used mainly for screening, not for diagnosis. It's not preferred diagnostically because the urine analysis would only be positive for glucose if the blood glucose is very high. If it's around 180, then you would have glycosuria. Glycosuria means glucose in the urine. And usually you should have absolutely no glucose in the urine, zero. So if there's anything at all, that's very suspicious and would indicate a positive screen for diabetes, although it is not diagnostic, as I said, because 180 is really high. The normal blood glucose level is somewhere around 120. So if for a patient to reach 180 without being diagnosed before, it's very unlikely. So that's why it's used for screening, not really for diagnosis. And again, each of them need to be positive on two separate occasions for you to make a diagnosis of diabetes. So that was the introduction. Now we're going to move on to the two types. The first type is type 1, and it is an autoimmune disorder. An autoimmune disorder is one in which your body basically attacks itself. It's this type of diabetes is usually symptomatic at a young age of 8 to 9 years, which is in contrast to type 2, which usually is symptomatic later in life. So this is a really important point. If in the question it says if it has symptoms of diabetes and the patient's a child, then you should start thinking of type 1. And how it works is the immune system attacks and destroys the beta cells of the islet of Langerhans, which you studied about. These are the ones that form insulin. This could be referred to as insulitis, the destruction of the beta cells. And it's initiated due to a trigger event. Now, basically, what happens is you have a trigger event, which could be a certain virus or a toxin. And when this trigger event happens, the body starts attacking the beta cells of the islet of Langerhans. Now, the actual reason for the trigger event, no one knows what the actual trigger event is. So no one knows the actual virus that causes the body to attack that beta cells. No one knows the toxin. So, but this is a hypothesis. But again, no one actually knows what the actual virus is or the actual toxin is. So basically, once this trigger event takes place, the T cells or the T lymphocytes are going to attack the beta cells and obviously destroy them. This is very important because the type 2, there's nothing like a trigger event. So the trigger event, if it's mentioned anywhere, or you have a question where there's something like a virus or a toxin, something like this indicates that there was a trigger event, which means it's probably type 1 diabetes that they're talking about. Now, when there is the autoimmune destruction of B cells, it doesn't happen at once. It takes actually a long time. So let's say if you have a patient, the trigger event was when they were 6 months old. Again, you don't know what the trigger event was. You're just assuming. Let's say it was a 6 months old. So this patient's body has been attacking itself since the patient was 6 months old. But they come to your clinic when they're 9 years old and they have the diabetic symptoms. And we'll study about diabetic symptoms. So can someone here tell me why it would take 8 years for the symptoms to show up? Why wouldn't it show up sooner? Can anyone answer?
Is it because you need the B cells to be destroyed? It needs time.
Exactly. So basically, when they're 6 months old, their body starts attacking themselves. but still they would have sufficient amount of B cells to continue producing insulin. Maybe not as much as they would normally, but still enough so that the body can perform the functions normally. But when they're 8 or 9 years old, so much, so many B cells have been destroyed that there's barely any left. As you can see, uh, once they get to that stage, 90% of their B cells are destroyed, which means there's only 10% remaining that are functioning. These B cells cannot produce enough insulin to uh, to do all the bodily functions that are required, and this is when they start showing symptoms because now their insulin is so low that it's actually affecting their life. Before this, it wasn't that low. It wasn't affecting their life, but now it actually is. So this is known when they start showing symptoms. This is when 90% of their B cells are destroyed, and only 10% are remaining. This is known as the clinical stage. It's known as a clinical stage because you have clinical symptoms that you can see, that you can, that the patient tells you, like, oh, this is happening, this is happening. That's the clinical stage. But before the symptoms, which is from the time of the exposure until they start showing symptoms, this is known as a subclinical stage because they have enough insulin from the remaining B cells that are not destroyed to continue performing bodily function. So they don't have any symptoms. That's why it's called subclinical. So the patient would have no idea that they have diabetes, type 1 diabetes, because they'd be fine because they have enough insulin. Not normal, but enough. So, do you understand clinical versus subclinical? Clinical is when you have symptoms, which is when 90% of the B cells are destroyed. Subclinical is no symptoms because you have enough insulin from the remaining B cells that are not destroyed yet. Okay, so there's only one treatment option for patients with type 1 diabetes, and that's insulin administration. Nothing else works, and that's why it also used to be called insulin dependent. So, insulin administration can be done in two ways. Either it's exogenous subcutaneous administration, which is basically you take insulin in a vial and administer it subcutaneously, which means in the fat, in the cutaneous layer, below the cutaneous layer, in the fat, or via an insulin pump. So insulin pump is a newer technology. Basically, you don't have to actually administer anything. It knows, it can test your blood glucose and it knows when it has to release insulin and when it doesn't have to. So genetics, so you might think that type 1 has a stronger genetic link, considering that it's an autoimmune disease, and usually autoimmune diseases have a genetic link. But you'd be wrong in thinking that because type 2 has actually a much higher percentage of genetic link than type 1. And a great example to demonstrate this is if one monozygotic twin has type 2 diabetes, then the chance that the other twin develops also diabetes is 100%, which means almost certain that the other twin will also develop diabetes. Whereas if one twin has type 1 diabetes, then the chance of the other twin developing it is only 30 to 40%. So as you can see, the link for type 2 is 60% more almost, which means there's a larger genetic component for type 2 than type 1. Although they both have a genetic component. So, but you need to remember which one is linked more to genetics. And the risk factor for the type 1 diabetes, as I said, is a trigger event, which could be a virus or a toxin. But again, we don't know what this is. This is a hypothesis, but it hasn't been proven, and no one knows what it actually is, unfortunately. So the symptoms of type 1 diabetes, well, this is only for type 1. It would also be for type 2, but we're doing type 1 right now. So the symptoms would be the three Ps. You need to remember this. It's super important. The three Ps are polyuria, polydipsia, and polyphagia. Polyuria means urinating excess. Polydipsia means drinking excess water, and polyphagia means eating excess. Okay? Let me repeat that. Polyuria is excess urine, polydipsia is drinking excess, and polyphagia is eating excess. In addition to this, you'd also have fatigue, weight loss, and weakness, sorry. And now we'll see why. Um, we'll see what the causes for this are. So we have for polyuria and polydipsia. Why does this happen? So we have a transporter in the kidney called SGLT. The full form is sodium dependent glucose transporter. What this does is that it reabsorbs the glucose that is excreted initially by the kidney. Because again, as I said, we don't want to excrete any glucose. Urine, usually, it has zero glucose. So that's the function of the SGLT, to reabsorb glucose. But once we have diabetes, we have so much glucose in the blood that the SGLT is saturated, which means it cannot function anymore. So let's say imaginary, we have 100 glucose in the kidney. The function of the SGLT, the max it can reabsorb is 70 glucose. After that, it gets saturated. It cannot absorb anymore. So the 30 extra glucose that shouldn't be there, but are there because the patient's suffering from diabetes, they would pass into the urine. They wouldn't be reabsorbed. And this would cause glycosuria. Now, what happens is when you have glycosuria, you have an increase in the osmotic gradient within the tubules. And from renal, you guys know that I don't know if you guys did renal, صراحة, but like, did you guys do renal? Can someone answer? Okay, so you did renal, great. Okay. So what happens is because of the excess glucose, the glucose it creates an osmotic gradient within the tubules because of which water also exits the body and enters the tubules, because of which you have excess water excretion. And when you have excess water excretion, you're losing water, which increases the level of thirst in the body because your fluid levels in the body are decreasing, and that's not good. So I hope you understood the osmotic gradient point. The next thing is polyphagia and weight loss. Why would that happen? Basically, we mentioned earlier that in diabetes, gluconeogenesis is stimulated because insulin is decreased. So we need metabolites for gluconeogenesis to take place. And where do we get these metabolites from? From eating. That's why we have polyphagia. Weight loss can happen in type 1 diabetes, and this is because there is decreased GLUT4 expression. As I mentioned earlier, GLUT4 is put in the cell membrane by insulin. So if there's no insulin, you'll have decreased expression of GLUT4, which means glucose cannot enter cells. If glucose can enter the cells, then the cells need another way to make the energy. They're not going to simply die. And the other way is lipolysis and rhabdomyolysis, which means basically the body's going to break down fatty tissue, adipocytes, and it's also going to break down muscles. They will use other complementary pathways to produce energy for the cells, which is why you would have weight loss. And then why would you have fatigue and weakness? That's because of the unintentional weight loss, because you're not actually intending to lose weight. You might be at a normal weight, but you would still lose weight if you were suffering from diabetes. Again, weight loss is mainly seen in type 1 diabetes. Type 2, usually the person is obese, and we'll go into this. But theoretically, you could see weight loss. But again, more common in type 1, not in type 2. The other three Ps and fatigue and weakness, you will see these in both type 1 and type 2. Now, let's talk about the metabolic changes seen in type 1, and this is probably the most important part of type 1 diabetes. The first thing you see is hyperglycemia. Again, this is super simple. You don't have GLUT4, which means the glucose can't enter the cells. If the glucose can't enter the cells, where is it going to stay? It's going to stay in the bloodstream. Secondly, we mentioned that there is increased gluconeogenesis and there's glycogenolysis, both. So that would increase glucose in the bloodstream again. What does this do? Excess glucose, so much glucose in the bloodstream, hyperglycemia. Easy. Hyperlipidemia is because the excess fatty acids, I mentioned earlier in the last slide, we have lipolysis because the body cannot use the glucose. What happens in lipolysis is we have excess fatty acids. And what happens is usually the fatty acids are oxidized so that you can use the energy from the oxidation for the function of the cells. And some of it will also be turned into ketone bodies, which we'll see later. But not all of it can be oxidized and turned into ketone bodies. You can ignore the ketone bodies part. We're going to study on the next slide. But not all of it can be disposed of this way. The rest of the fatty acid is actually converted into TAGs, triacylglycerols, and transported via VLDLs to the adipocytes. I'm sure you studied about VLDLs in the plasma lipoproteins lecture. But if you didn't, then VLDLs basically they transport tags to the adipocytes. Uh, but remember, I told you earlier that the activity of lipoprotein lipase is low in diabetes because this is stimulated by insulin. The hormone sensitive lipase has an increased activity and lipoprotein lipase has a decreased activity. So since the lipoprotein lipase activity is low, it can't break the VLDL and chylomicron so to store the fatty acids. So what happens is the VLDL and chylomicrons keep building up and accumulating in the plasma, and this causes hyperlipidemia. Again, really simple. Since the lipoprotein lipase doesn't work, the VLDL and chylomicrons cannot be broken down. If they can be broken down, they keep accumulating, and once they accumulate, there will be hyperlipidemia. Easy. And now, probably again, the most important thing in type 1 is diabetic ketoacidosis. Uh, it's something that doesn't happen to every patient, but if your disease is poorly managed, then you have a high chance of, especially type 1, they have a high chance of having DKA. DKA is the short form of diabetic ketoacidosis. So in patients with diabetes, glucose cannot be utilized. As I said earlier, there's no GLUT4. So the body focuses on lipolysis. Lipolysis leads to the formation of large amounts of acetyl coenzyme A. The breakdown of fatty acids, you get acetyl coenzyme A. I don't even remember the pathway, it was 2 years ago. I'm sure you guys do because you need to remember it. Anyways, you have acetyl CoA. And when this acetyl CoA keeps accumulating, it's converted into ketone bodies. Again, this is a short, simple pathway of how acetyl CoA is converted into ketone bodies. Now, what should happen usually if you have lipolysis is that the acetyl coenzyme A would be incorporated into the TCA cycle, the tricarboxylic acid cycle, but all the intermediaries of the TCA cycle are being utilized for gluconeogenesis. So you know all those things in the TCA cycle, oxaloacetate and others. Sorry, that's the only one I remember. They usually what would happen is that this acetyl coenzyme A would enter the cycle and then energy will be made. But what happens now is that all of the things that are part of the TCA cycle are removed from the cycle and they enter the gluconeogenesis pathway. Because as I said earlier, in diabetes, gluconeogenesis is promoted. So now this acetyl coenzyme A has nowhere to go. It becomes a ketone body. The ketone body can cause ketoacidosis. The ketone bodies are acidic in nature, and again, once there's accumulation of them, they cause the blood to become acidic, and this causes ketoacidosis. And this is very harmful because, again, the blood pH is tightly controlled, as I'm sure you know. It should be between the range 7.35 to 7.45. If you have ketoacidosis, it's going to fall below the 7.35, and the patient is going to be in a lot of danger. Now, DKA usually happens in patients with type 1, and it's not as common in type 2. Can anyone tell me why? It's more common in type 1. It's also on the slide, but can someone tell me why it's more common in type 1? Can anyone tell me why it's more common in type 1? Exactly. Because both of you are correct. In type 1, there is absolutely zero insulin. I mentioned this earlier. But in type 2, there is decreased insulin, but there is still some insulin. It's not normal levels, it's decreased, but there is some. So since there is some amount of insulin, DKA is less common in type 1, in type 2, sorry. In type 1, there's no insulin. The body is completely dependent on insulin that you will give them via the subcutaneous route or the pump. But yeah, exactly. That's right. If there's no insulin, the chances of DKA are higher, which is why it's more common in type 1. Type 2 still have some insulin, not normal amounts, but still some insulin, which would make it harder for them to enter the state of DKA. Again, DKA would be more common in diabetic patients that are suffering from stressors and infections. Stressors as in mental stress and physical stress both. The reason for this is because during stresses and infections, we have the release of epinephrine, norepinephrine, and cortisol. And all of these oppose the action of insulin. So even the diabetic patients are already low on insulin. Now you're releasing some hormones that are again going to oppose insulin. So they're going to fight against insulin, which will make it more likely for them to develop DKA because the level of insulin would lower. So again, DKA is more common when a diabetic patient has stresses and infections, and it's more common in type 1 than type 2, although it can happen in both. Now, hypoglycemia in type 1 diabetes. You might be asking me, hypoglycemia doesn't diabetes cause hyperglycemia? And you'd be right, it does cause hyperglycemia. Hypoglycemia doesn't happen due to type 1 diabetes, but it happens to a lot of people that are suffering from it due to a mistake in medication. or a mistake in the dosage. So a patient with diabetes may go into a state of hypoglycemia if they take an excessive insulin dose. So if you take an insulin dose that's more than recommended by your doctor, or if you forget to eat after taking insulin, then you're at risk of hypoglycemia because the insulin will move all of the glucose in the bloodstream into the cells, which means you will have hypoglycemia. Normally, the body, if like in a patient that doesn't have diabetes, the body can, if like let's say you're a normal person, you don't have diabetes, then the body can regulate insulin release during hypoglycemic state. So let's say you have hypoglycemia, the body senses it and it releases glucagon, which promotes glucose release. So again, you were in a hypoglycemic state, but because of the glucose release, you're now in a normal state. But when you have type 1 diabetes and you are in a hypoglycemic state, the body cannot compensate. And it can't compensate because the alpha cells are also damaged. To refresh your memory, the alpha cells are the ones that release glucagon. So if there's less glucagon release, glucose is not going to be released. In addition to this, in diabetes, you also have peripheral neuropathy, which I mentioned earlier, because of the protein structure being damaged by the glucose, excess glucose, which means there is less norepinephrine and epinephrine release. Now, glucagon increases glucose. So if you have less glucagon, you're not going to increase the glucose. If you have less norepinephrine and epinephrine, these both combat insulin. They decrease the function of insulin. So if you have less of them, then insulin function is going to remain normal. Both of these things mean that the hypoglycemic state cannot be corrected in the body, and this is extremely dangerous because it can lead the patient to faint and eventually be in a coma if it's not corrected quickly. So all the self-regulation abilities of the body are lost. So normally the body would be able to pull itself out of a hypoglycemic state by the two mechanisms I told you. But in diabetes, both of these mechanisms are also damaged, which means the body cannot pull itself out. So again, that's why it's very important for them to take the correct dose and to eat after they take insulin. And this is also why in movies, sometimes when someone diabetic faints, you give them something sweet, you give them orange juice or sugar or honey, something that would raise their blood sugar immediately so that they are no longer in a state of hypoglycemia. That's it for type 1. Tell me if anyone wants to ask me anything. Uh, Also, Ahmed, you asked me to repeat something, but I didn't see what it was. So you can tell me right now what you want me to repeat before we go to type 2. Okay, perfect. All right. Type 2 diabetes, we're halfway through the lecture, and this shouldn't take too long at all. Um, so type 2, remember, type 1 was autoimmune. Type 2 is not autoimmune. First things first, type 2 develops gradually, and usually there's no symptoms. So even at the time of diagnosis for these patients, they may have only some symptoms or no symptoms at all. And the reason for this, as mentioned earlier, is because they still have insulin. They do not have enough insulin, but they have some insulin because of which they can perform their functions normally. That's why when these patients are diagnosed, even they may not have symptoms. Whereas in type 1, they're going to have the symptoms when they're diagnosed because all of the insulin is gone. It's completely destroyed. The body cannot perform normally. Now, type 1 was autoimmune destruction. Type 2 happens due to insulin resistance and the dysfunction of beta cells. The insulin resistance causes the dysfunction, but both of them are a reason for type 2 diabetes. And we'll discuss more of these in the next slide. But for now, insulin resistance and dysfunction both cause type 2. The metabolic changes are similar to type 1, so we won't have to go over them again. You will have hyperglycemia because of the same mechanism. You will have hyperlipidemia, again, because of the same mechanism. The only difference, as mentioned earlier, is the incidence of DKA is less, as there's always some insulin production for the body to perform its functions. Whereas in type 1, if you don't have insulin, then you're done for because you have absolutely zero insulin. The body is going to suffer and you're going to go into DKA. Again, remember, this was called non-insulin dependent. And the reason for this is they do not require insulin if lifestyle changes are made immediately. However, 90% of people with type 2 still will end up using insulin. And the reason for this is because most people are not able to control the disease, are not able to restrict themselves, are not able to make correct changes in their lifestyle, and they eventually end up requiring insulin because now the disease has progressed too much for it to be treated with medications or with lifestyle changes. But theoretically, if you catch the disease early and you make lifestyle changes, you will not need to use insulin, which is why this was initially called non-insulin dependent. But again, that's not true anymore because these people do use insulin as well. Okay, so how do you diagnose it? It's the same way, the same exact thing which we mentioned earlier. For both type 1 and type 2, they're diagnosed the same way. So if the fasting plasma glucose levels is elevated over the normal range, but it is not yet at the diabetic threshold, the patient is said to be pre-diabetic. Again, I mentioned this earlier. If it's higher than normal but not above the threshold, it's pre-diabetic. Pre-diabetic means you are at a way higher risk of developing diabetes, but you don't actually have it yet. But it also means that this is a wake-up call, and you need to make a lot of lifestyle changes to make sure that you don't eventually progress into being a diabetic. The major risk factors for type 2 are obesity and sedentary lifestyle and genetic predisposition. As I said earlier, it has a very strong genetic component. Obesity is again a major risk factor, and basically, a person with a person that's very heavy, that's fat, would have increased insulin resistance. And when you lose this weight, so let's say someone is 5'5" and 100 kilos, they would have a much higher risk because their insulin resistance is going to be a lot, which means the body is not going to be able to use the insulin. Whereas once this person who's 5'5", he's 100 kilos, he loses 20, 30 kilos, let's say he's 70 now, the insulin resistance would decrease. So the body would be able to use the insulin that is being produced. That's why obesity is a major risk factor. Sedentary lifestyle is another risk factor. So exercise, walking, all of this stuff does help decrease the chances of type 2 diabetes. An acute complication that can happen in type 2 diabetes is hyperosmolar hyperglycemic state. This is super important. So the acute complication that is most likely associated with type 1 is diabetic ketoacidosis. The acute complication that's most likely with type 2 is a hyperosmolar hyperglycemic state. And what happens is you have an episode of severe hyperglycemia. This could be due to eating a fatty meal or not taking your insulin. Not sorry, not a fatty meal, a sugary meal. Let's say like a cheesecake. And in addition to this, you don't take your insulin dose on time. What's going to happen? You're going to have severe hypoglycemia. What happens with severe hypoglycemia? Again, the glucose is going to be excreted into the tubules, which means the water will follow it. You'll have severe dehydration because all of the water is leaving because of the osmotic gradient, which means you're going to be dehydrated, you're going to have a high glucose, and this is basically hyperosmolar hyperglycemic state. It's a dangerous thing. But yeah, simple mechanism of how it happens. Now let's talk about insulin resistance. Now, insulin resistance is the main cause for type 2. How does it happen? It's mainly due to the adipose tissue secretion, which is again why I said obesity is a major risk factor because the insulin resistance is mainly due to adipose tissue secretion. And adipose tissue, or adipose, whatever you want to call it, is fat tissue, obviously. Adipose tissue releases inflammatory cytokines like interleukin 6 and leptin. Leptin is normal, it's physiological to be released, but if you have excess adipose tissue, it's going to release excess leptin. And the adipocytes also suppress the release of anti-inflammatory adiponectin. So these three you need to remember: IL-6, leptin, which is inflammatory, both of these are inflammatory, and they're released by adipose. And adiponectin is anti-inflammatory, and its release is blocked by adipose. Now, what happens is the net effect of these three is that it makes it much harder for insulin to exert its effect on the body. So initially, in type 2 diabetes, the insulin is normal. Like the insulin, there is enough insulin. But what happens is the body cannot use this insulin normally because of these three things. So tissues such as the brain, liver, muscle, adipocytes are unable to respond to the circulating insulin levels due to these three reasons I mentioned above. And then once this insulin resistance is solidified, what happens is that the body notices, wait, the function of insulin isn't being fulfilled because of the resistance. But the body doesn't know the resistance. So what it's going to do is it's going to make more insulin. It's going to think the insulin levels are low. I need to make more insulin. So initially, in type 2 diabetes, once the insulin resistance is solidified, you're going to have more insulin secretion from the B cells than normal to compensate for the resistance and to keep the blood glucose levels normal. So the body is going to try its best to combat the resistance by increasing insulin. But eventually, the beta cells malfunction under the expectation of continuously excessive insulin secretion. So the beta cells can increase insulin levels, but it can't maintain this increase because uh, the insulin levels that are normally secreted, it's not made to go over that. At the start of the diabetes type 2, it does go over it to maintain blood glucose normal, to combat the resistance. But eventually, it can no longer uh, combat the resistance, and the insulin levels now decrease. And why does it decrease? Because the beta cells are malfunctioning because of the expectations. Like they were expected to release so much insulin to combat the glucose levels in the blood that now they just stop working. They're destroyed. They're dysfunctional. So as you can see, the mechanism for type 1 and type 2 is different. In type 1, the beta cells are destroyed by the body, whereas in type 2, the beta cells malfunction because they have to produce so much insulin in the start. So when the insulin levels decrease later on, because the beta cells can no longer keep producing so much, the blood glucose levels increase, which is what leads to hyperglycemia. So at this point, the symptoms of diabetes become obvious because the blood glucose is so high and the insulin is low. But again, this is at a very late stage. Most people are diagnosed before this point. So the name of this phenomenon that I was mentioning is transient hyperinsulinemia, followed by a decrease in insulin secretion. So the transient increase in insulin is because the beta cells are trying their best to combat the resistance, but then eventually they can't do enough. They die because we're expecting way too much from them, so they just give up. They dysfunction, and this reduces the insulin secretion because of which the blood glucose goes high. And we have a graph illustrating this here. The top part of the graph, the blue line is basically showing us the fasting blood glucose in type 2 diabetes. This is a patient that's untreated. So you can see initially the x-axis is the years of diabetes. So you can see when he has diabetes, the blood glucose barely increases because the insulin is trying so hard. It's increasing the amount of insulin so that the glucose remains normal. But as you can see, after 10 years of diabetes, the blood glucose is increased uh, noticeably. After 15 years, even more. After 20, even more. And why does this happen? Is because the beta cells are dysfunctioning. They can no longer produce a lot of insulin, which means the fasting blood glucose goes up. The blood glucose in general goes up. Initially, it's controlled. After that, not really. It goes up a lot. You can see after 20 years, it's almost at 220 mg per deciliter, which is extremely high. The second graph with the yellow line at the bottom, it shows us how the insulin levels. So you can see this patient has diabetes and his insulin here, it's increasing. You see this peak here? The insulin is increasing a lot to make sure that the blood glucose doesn't increase. But after 5 years, you can see here, after 5 years or after 10 years of having diabetes, the insulin levels go back down and eventually they go even lower than normal. Initially, they were higher than normal, now they're lower. And the reason they're lower is because they're giving up. They can't function anymore because of the expectations that are put on them to produce so much insulin. And you can see point two here, it's pointing towards the yellow line and the blue line. You can see when you have so much insulin, the blood glucose is normal. But at point three, when your insulin is decreased below normal because of the dysfunction of the beta cells, the glucose level is extremely high. I hope that's clear because it's really important. And you may get an MCQ from this concept because this is one of the most important concepts in type 2 diabetes. If it's not clear, you should ask me now. Okay, I guess it's clear. So, who does type 2 diabetes happen to? Well, it can happen to anyone, but most likely it happens to the elderly people. And the reason for this is senescence-related beta cell dysfunction, which basically means it's a physiological mechanism wherein the beta cells cannot produce enough insulin when the person gets older. Like it happens naturally, it's not disease-related. And this eventually causes diabetes, which is a disease. It happens in obese people, again, because of the adipocytes, which increase insulin resistance. If you have lack of exercise, again, that also can lead to type 2 diabetes, especially if you're overweight, and pregnant women, which is the gestational diabetes. And again, we'll come to gestational diabetes on the next slide. Again, due to insulin resistance, hormone-sensitive lipase may not be inhibited. As I mentioned earlier, if you do not have in diabetes, you have less insulin or insulin is not functional, as in type 2, it's resistant, uh, you will have decreased function of lipoprotein lipase and increased function of hormone-sensitive lipase. Now, what does hormone-sensitive lipase do? A quick review. It causes the breakdown of tags in the adipocytes and it causes the release of free fatty acids. Now, when this is not inhibited, it's continuous. It's going to keep breaking down the adipocytes into fatty acids, right? Which means there will be an increase in fatty acids within the cells and in the bloodstream. So that's one of the mechanisms of how hyperlipidemia happens in diabetes, and it also interferes with the insulin secondary signaling. I don't know if you have taken this already, but you will take cell signaling, and you will see there how basically secondary signaling works. But basically, what you need to remember now is the fatty acids accumulate within the cell and they interfere with the secondary signaling, which is needed for insulin secretion. So if this doesn't happen, insulin won't be released. The other thing that can happen is because of the increase in free fatty acids, you can have a disease called hepatic steatosis. This is commonly referred to as fatty liver. And again, this is because of the increase in the free fatty acids. You should remember this. How do you treat type 2? The first thing is lifestyle changes. You can exercise to lose weight, diet to lose weight, because as I said, adipocytes are the main reason for insulin resistance in the first place. But there's also some medications. Remember, for type 1, there is no medications. The only medications are for type 2. Type 1, there's only one treatment, which is insulin. The medications for type 2, we'll go over them in the next slide. The complications of diabetes in general are retinopathy, neuropathy, and nephropathy. All of these happen due to glycation, as this is already mentioned earlier. And the last thing is premature atherosclerosis. Again, the reasoning for this is that the excess glucose sticks to the blood vessel walls. It forms plaques. It plays a role in the formation of plaques. And then basically this narrows the blood vessel, causing atherosclerosis. The retinopathy, neuropathy, nephropathy is due to the glycation of proteins, and because of which the proteins can't perform their function, which is why you would have neuropathy, you can't feel properly in the peripheral limbs. Retinopathy, you will have visual changes. Again, you need to be on the lookout for symptoms like visual changes, tingling, some problem in the kidney, because all of these are clues that are pushing you towards diabetes. Now, how can you prevent diabetes? For type 2, if you maintain a normal body mass index and you exercise, you keep your weight at a good, you keep your weight normal, not overweight, then that's a very good way of preventing type 2 diabetes. But nothing can prevent type 1 diabetes. As I said, the, how does type 1 diabetes start? It starts because of the trigger event. The trigger event tells the body to attack the beta cells, but we don't know what the event is, so we can't prevent it. So basically, there's nothing we can do. And it's all up to Allah, whether you get it or not. Now, what are the medications that are used in type 2? They probably won't focus on this too much, so I won't go into a lot of detail, but the medications that they use are metformin, sulfonylureas, thiazolide, imidiones, GLP-1 agonists, DPP-4 inhibitors, and SGLT2 inhibitors. So I'll just go over what they do really briefly. Metformin basically decreases the glucose production and increases the glucose uptake in the peripheral cells. So basically, it reduces the glucose in the bloodstream, which so it basically combats the hyperglycemia. And metformin is the first line drug for type 2 diabetes. Sulfonylureas is another drug that's used, and basically it inhibits these K channels present in the beta cells. And when it inhibits the K channels, there is an increase in insulin secretion. But yeah, these are not commonly used anymore because they have an increased risk of weight gain and some other stuff. So not really used anymore. The third one, thiazolide inhibitors, I don't even know how to pronounce it. Again, third line, not used commonly, and its mechanism of action is that it decreases the insulin resistance. So the other two did not do that. They increase insulin or decrease glucose. This one decreases insulin resistance. Then you have GLP-1 agonist, semaglutide. This is very common nowadays. Like Ozempic is an example of a GLP-1 agonist. What it does is that it increases the glucose-dependent insulin secretion. It delays the gastric emptying, so it keeps you full for longer, and it decreases your appetite, so you eat less. So it promotes weight loss and diabetes. Like initially, this drug was for diabetes, but now a lot of people use it for weight loss because it reduces your appetite, so you eat less. Then we have SGLT2 inhibitors. Again, SGLT is the transporter that is present in the kidney, which is responsible for glucose reabsorption. So basically, what an inhibitor of this does is quite obvious. It increases the excretion of glucose, which is good if you have diabetes because you don't want excess glucose. You want to excrete the glucose so that the glucose that is reabsorbed is a normal amount. So that's why an SGLT2 inhibitor is also used occasionally. Again, not first line. Then we have DPP4 inhibitors. So DPP4 basically breaks down GLP-1. And as I mentioned for the GLP-1 agonist, what GLP-1 does is that it increases glucose-dependent insulin secretion, it delays gastric emptying, and it decreases appetite. So DPP4 breaks down GLP-1. That's why if we inhibit DPP4, we're going to have an increased level of GLP. And that's why DPP4 inhibitors are also used in some cases. Again, not first line. First line is metformin, and that's the most important one. Again, medication is not that important. If you're on a time crunch and you don't have time, then I would recommend leaving it. But if you do have time, then just go over like just a quick mechanism of action. You don't need to know the details. Just metformin is really important. Remember metformin. Gestational diabetes, as I said, is a type of type 2 diabetes. It's a subtype. So it's a diabetes that may happen during pregnancy. It can cause fetal macrosomia, which is basically a newborn that is significantly larger than normal. So they will have increased weight. All right, the newborn is going to have increased weight. That's called fetal macrosomia. The baby may also have transient hypoglycemia, so which means that the baby produces excess insulin in response. So the reason this happens, the transient hypoglycemia, is that when the baby's not born yet, they're still uh, like before delivery, the baby produces excess insulin in response to the increased blood glucose in the womb, because the mother's blood has excess glucose, it's hyperglycemic, so the baby produces insulin to use the glucose. And so because you don't want the baby to have hyperglycemia, so the baby produces insulin. So once it's born, it's no longer going to be connected to the mother's bloodstream because of the umbilicus being severed. The connection between the mother and the baby is the umbilicus. When you're born, the umbilicus is cut off, which means there is no connection between the baby and the mother. The baby is still going to produce the excess insulin because that's what it's used to, since the mother's bloodstream had so much glucose. But now it's no longer connected to the mother's bloodstream, which means it just has its own blood to take care of. But it's producing too much insulin, which means there's going to be hypoglycemia because all of the glucose is going to enter the cells, and there's going to be a stoppage of glycogenolysis, and there's going to be stoppage of gluconeogenesis. All of this is going to cause a decrease in the blood glucose, which is transient hypoglycemia. But again, this is transient, which means it doesn't remain. It eventually corrects, and the baby's blood glucose goes back to normal. Once it realizes that, oh, there isn't that much glucose, I should stop producing so much insulin. I hope that's clear. And why gestational diabetes happens is because in pregnancy you have an increase in cortisol, you have increase in HPL, human placental lactogen, and both of these are basically combat insulin. They're against insulin's action, which can eventually lead to diabetes. It's not common; it only happens in about 5 to 10% of pregnancies. But yeah, again, it's really important because it affects the baby, fetal macrosomia, and transient hypoglycemia. Okay, we're done with everything. All I'm gonna do is we have two slides. For one is for graphs and the other is for basically a quick summary. So this first graph is basically showing us insulin secretion in type 1 diabetes. You can see the insulin secretion initially is normal, but later it goes down. And as you can see, the trigger event is over here. After the trigger event, the beta cells start dying, which means the insulin steadily decreases. But the levels are normal because it's enough to maintain the function of the body, but not enough to, but it's enough to maintain the function of the body, but again, it's decreasing. And then eventually, when it gets to this red part, the clinical threshold, the insulin level is too low for the body to function normally, which is when you start having symptoms. And this is when they're usually diagnosed with type 1. So as you can see, it's a steady decrease, kind of linear almost. This is in type 1. This graph shows us that for a patient that has insulin resistance, the blue lines are a normal patient, and the red lines are a patient with insulin resistance. So you can see the red lines are so much higher than the blue lines. So whenever a patient with insulin resistance eats, the body needs to produce so much excess insulin versus a normal person to maintain the blood glucose. And this is why eventually the beta cells burn out, they become dysfunctional, and this eventually leads to type 2 diabetes. This is a very nice slide. I would recommend you read this on your own time. Very good, quick review for the whole lecture. Okay, we're done. We're gonna do questions now. I want you guys to read the question and then answer. So yeah, go ahead. Read this question, please. You don't have to read it out loud, just answer the question. You can answer it, like unmute or in chat, both. So is no one gonna answer? Okay, so you said A, B, and D. Let's see if you're right. I'll go through each option and then I'll explain why it's right or wrong. So option A is insulin resistance primarily results from the secretion of anti-inflammatory molecules by adipose tissue, which facilitates insulin action. But this one is incorrect because insulin resistance is due to the secretion of inflammatory molecules. Remember IL-6 and leptin? Those are inflammatory, not anti-inflammatory. So option A is wrong. B. In response to insulin resistance, pancreatic beta cells initially increase insulin secretion to maintain normal blood glucose, but then this compensatory mechanism may eventually lead to beta cell dysfunction. This is correct. This is literally the whole mechanism of type 2 diabetes. Third one. Tissues such as the brain, liver, muscle, and adipocytes enhance their response to circulating insulin levels, thereby preventing the onset of hyperglycemia. This is incorrect because, as mentioned earlier, when you have insulin resistance, all of the tissues in the body struggle to use this insulin, and hence, which is why you're going to have hyperglycemia. They can't use the insulin uh, in a normal way, which means you're going to have hyperglycemia. That's the whole point. So the option C is wrong as well. D is the secretion of inflammatory cytokines like IL-6 and excess leptin from adipose tissue has no significant impact on insulin signaling and glucose metabolism. Again, this is incorrect as well. So yeah, because obviously you have inflammatory cytokines, they basically lead to dysfunction, insulin resistance, all of that. So a correct answer would be B only. Only B is correct. The rest of them are wrong. Is that clear? All right, perfect. Yeah, seems like you guys understood. Perfect. Next question. I'm gonna give you like 30 seconds to answer it, then I'll start explaining. Okay, perfect. You said B. Let's see if you're right. The first one, diabetes during pregnancy can lead to fetal macrosomia. Boom, that's correct. Newborns may experience transient hypoglycemia due to excess insulin production in response to elevated maternal blood glucose levels. That is also correct. The risk of developing gestational diabetes is primarily associated with maternal age and obesity. Also correct. Babies born to mothers with gestational diabetes are often smaller than average due to inadequate nutrition supply in utero. That is incorrect. As you know, they suffer from fetal macrosomia, which means the baby is larger than normal. So A is correct because fetal macrosomia, that is correct. Second, transient hypoglycemia, also correct. Third, Gestational diabetes. I mean, I didn't really cover this, but it is also correct. They will not ask you anything that you didn't cover. But gestational diabetes is related to age and obesity. So if the mother before pregnancy is obese, then you have an increased chance of having gestational diabetes. And if the maternal age is higher than normal, so let's say late 30s, then you also have an increased risk. But yeah, so A, B, and C are correct. D is incorrect. Okay, 30 seconds, and then I will answer it. Okay, so one of you said B and one of you said B and C. Let's see. So DKA primarily occurs in type 2 diabetes. This is wrong because DKA occurs in type 1. So 1A is wrong. B, the accumulation of ketone bodies in DKA is a result of increased lipolysis when glucose utilization is impaired. This is correct. And this was mentioned in the slides. C, in DKA, the intermediates of the TCA cycle are predominantly used for gluconeogenesis, preventing normal energy production. Correct. So C is also correct. D, stressors such as infections can trigger DKA in diabetic patients due to the release of hormones that antagonize insulin effects. That is also correct because remember, in infections, you have release of cortisol, norepinephrine, epinephrine. All of these are against the action of insulin, which means the likelihood of DKA is higher because insulin levels are already low, and now you're lowering them further because of these hormones. So what's correct is B, C, and D. They're all correct. And both of you said B and C. Well, yeah, B and C are correct, but so is D. D is also correct. All right. Last question, 30 seconds, and then I'll answer it. Okay, both of you said A and D. Let's see if you're right. Type 2 diabetes is predominantly observed in elderly individuals who experience increased insulin resistance due to age-related stuff. Yes, that is correct. A is correct. B, obesity contributes to type 2 diabetes through the inhibition of hormone-sensitive lipase, preventing the breakdown of triglycerides in adipocytes. Again, this is incorrect because hormone-sensitive lipase is promoted and lipoprotein lipase is inhibited in type 2 diabetes and in type 1 as well. So B is incorrect. C, regular exercise has no significant impact. I mentioned that exercise does help prevent type 2, so this is incorrect. And D, gestational diabetes is a form of type 2 diabetes that can occur during pregnancy. And okay, yeah. So D is correct as well. So both A and D are correct. Yeah, you both are right. And with that, the session ends. Thank you so much for attending. I hope it was beneficial. I tried to make it as simple as possible. I tried to explain everything. Um, Please scan the QR code, or I could lose my job, and I really like my job, so please scan it. And yeah, thank you so much for attending. Any questions, reach out to me, not only about MOL, about first year, or about uni in general. And yeah, thank you so much.